And we're live. Okay, my friends, in the efforts of beginning on time, but also honoring that you're taking a moment to stretch, that is a-okay. We hope to see your beautiful faces here when you're ready. I have so many privileges this week, and I have another great privilege this evening to continue to orient us to the evening and to the day, and specifically to this incredible session with two wonderful friends of ours here at AMSA. We have been focusing on many different ways to uplift our fight for taking back our democracy. And as we work to radicalize AMSA more and more, which has been such a gift that each of you have been a part of, as we rethink and re-envision what advocacy means to us, especially in the environment that we're living in, we have chosen to be continuously clear and direct about our values. And as we just spoke about here this evening, that can be scary, and that's okay. And if there's one, I shouldn't say if there's anything I want you to take away from this week, but if there's one big thing I hope that you'll take away from this week, it's that visibility can be frightening as you do this fight. However, simultaneously, it is so rewarding because as we come closer and closer to our values and we get to know our values as people and as future providers, we become closer to who we've always been and who we're supposed to be. And that is the greatest gift, irregardless of where we go in our lives and what we do for work. When we're showing up authentically, everything aligns differently. So I hope that you'll know that clarity is kindness, as Brene Brown says, and that is a compass for me. And I hope it can be a compass for you as we look at our very clear programming, which I am very proud of and have had the pleasure of building with so many of our wonderful AMSA members. So today we talk about reproductive justice, reproductive care, as I mentioned earlier, full spectrum access, what it means to uphold reproductive justice as a human right, what fights on autonomy look like, what fights against abortion look like, and how we can be providers that are equipped to not only face those challenges with knowledge, which is a lot of what we'll be learning here this evening, a lot of very important knowledge, and also that we will have that spirit of confidence that we are again staying in true alignment with what our patients need from us, which is non-judgment and showing up at the door ready to care for them, irregardless of their decisions and their background and where they're from. You care about a person. You don't get to choose farther than that. In medicine, at least I'll say, hopefully in the world. Now, without further ado, I want to, hi, Leah. I want to say hello to our wonderful two speakers this evening, Dr. Leah Runyon, our AMSA reproductive health strategist, so our very own OBGYN abortion provider, tireless advocate, has been working with us here at AMSA for quite some time. Hopefully you know her, and if you don't, I'm really excited for you to hear more about her this evening. She has been directing her clinical care experiences there in New Jersey. She has been working to uphold and protect rights to abortion care. She's just an activist at heart. And that's why she got along so well already with our beautiful Sophia Bronstein. I have had the pleasure of just meeting Sophia most recently as I put out an ask for HIWA. Sophia comes from a long line of advocacy, serving as an abortion doula in her past, working at IBIS Reproductive Health. I'm going to put links to this in the chat if you didn't get a chance to look these places up before. A case manager at the DC Abortion Fund. She is, again, an activist at heart. She's worked on research, been a research manager. She has been on the ground with patients, and she has had that same spirit of advocacy that we love and that we uphold here at AMSA. So you didn't come to listen to me talk. You would think that you did. So I'm going to pause here and allow my friends to take it away. Thank you so much.
Thank you so much, Tanya. It's lovely to be here with you all. I'm going to let Sophia start us off.
Thank you, Tanya, for that beautiful introduction. And it's such an honor to be with you here today. I know it's like a late night. I know you all have so many things going on, and so we're just Excited to be here with you all and get to talk about demystifying self-managed and medication abortion, what future clinicians need to know. And we are hoping that this is more of an interactive conversation. So the way that we've structured this is um, with some questions that we're going to be posing to you all that you'll hopefully participate in. And you're welcome to come off mute. You're welcome to ask questions in the chat. And we'll be sharing, like our screen a few times to like share some images just for, I mean, I'm a visual learner, so for the visual learners out there. But ideally, this is just more conversational. And some of this information might be new to you, some of it might just be familiar. So we really just also want you to chime in with your own expertise and your own experiences. So just know that we're really welcoming that. And I guess to start us off with that, if y'all could begin by just putting your names in the chat along with the school that you're from or that you are affiliated with, as well as the state that you like live in or reside in. That would be wonderful just to ground us a little bit in terms of where folks are coming in from. And we're just essentially going to talk through a little bit of like the abortion context that we are finding ourselves in right now. Then we'll, talk a bit more about like medication abortion, self-managed abortion, and then also, end with talking more about the role that you all have as clinicians and what you can do to best advocate for your patients in this really difficult time that we are in right now. And just really grateful that you're all on this call and that we have providers that are, willing to ensure that people have access to abortion. I think that's just so, I know it takes a lot of bravery and courage. And so just want you to know that I see that. So to start us off with the context, I think many of you all know that we, since 2022, from when the Dobbs v. Jackson decision from the Supreme Court struck down Roe v. Wade, abortion is now being regulated at a state level. And so it's a little bit like the Wild West. Access is very different from state to state, I think, as many of you all know. And also, despite all those restrictions, abortions are still happening. These restrictions aren't eliminating abortions. They're just reorganizing the way that people are getting care, so making it harder for people to get care, but people are still out there seeking abortions and getting abortions. It's just like the circumstances and where they're getting them has changed. And so, and if anything, like from the latest data we have, we know that abortion rates have gone up 12% in the formal healthcare system from 2020 to 2024. So that includes, even after the Dobbs v. Jackson decision in 2022. So these abortion restrictions are not working the way that politicians want them to, which is, I think we're adapting and innovating with the times. And what I'm going to do is I was going to share my screen to share a map that you might have seen before from the Center for Reproductive Rights. See how my screen sharing is working. Great. Are you all able to see my screen? Awesome with the map.
Yes.
Wonderful. It's like my screen is kind of confusing. Great. So I wanted to ask you all to share. I know you shared where you were from in the chat, so thank you so much for that. But I'd love to invite you all to come off mute and share where you're from or where you currently find yourself, where you're currently living, and then what's the abortion context in your state. Just like share with us like what you know, maybe what you see on this map. I guess just to guide us here a little bit with the image before you all dive in. I think, green clearly is like states where there's expanded access. So that's like California, Oregon, Washington, Illinois, New York. In yellow, we have states that have protected access. In orange, states that currently don't have any protections for abortion. And then kind of in the red and like in the darker brown, we're seeing like states that are hostile or where abortion is fully banned. And so you can see that this is a very varied map. And would love to hear, from you all kind of what you're seeing in your states, what your experiences are. You can either just come off mute or raise your hand and we can call on you.
Hi, this is Sherry from New Mexico. I was wondering what you meant by non-protections by the.
Hi, Sherry. Sorry, what could you repeat that again?
What can you clarify what you meant by no protections, the orange part of New Mexico?
Yeah, that's a great question. So here, for example, it's like hover on New Mexico. So in some ways, like the way the legal landscape in New Mexico, there is a law that was passed in 2023 that ensured access to reproductive care, including abortion, but it's not as like protected, for example, with like shield laws, or kind of other more expansive legislation that's like affirming access. But since you're from New Mexico, I'd really love to hear from you in terms of like your experiences on the ground, and also if that just doesn't feel accurate to you. That's what this map is saying, but and how like the Center for Reproductive Rights has evaluated that legal landscape, but it might feel different to you on the ground.
It's really interesting because, like, I agree that there's almost nothing that's protected anymore. We'll be honest. But with New Mexico, the hardest parts that I've seen are in the past, the shuttering of a lot of clinics, because abortion is legal in New Mexico. But there's anti-discrimination laws. So that's how we get to cover it. I hope you can still hear me.
You're coming through,
And
yeah.
so I am a Medicaid enroller, so our Medicaid covers it. Right now, I'm very hopeful because we're seeing a lot more clinics open. Like just in the last few year or so, we've had a bunch more clinics open, and this is pretty much just for the medication part. The surgical part, there's still very few that do it. The parts where it's really difficult is the new Medicaid insurance companies. One of them doesn't cover it without a lot of loopholes. So that's the company that's been in the news and what we associate Luigi with. So I'm not going to name names, but but yeah, you got to get a lot of prior authorizations, and that's often not possible, and they're not reimbursing from what I can tell on the ground. But I do Medicaid for adults, pregnant people, kids, and I'm one of the only enrollers who outwardly does it for the abortion clinics. So that's my experience on the ground. So actually, some fight. But our insurance companies are a different story. So none of our Obamacare insurance companies cover it without a lot of loopholes, but our Medicaid does. So when it comes to employment insurance, it's really all over the map. But you can have employment insurance and Medicaid, so that could be a way of covering it. Or TRICARE. So we got a big military presence in New Mexico that doesn't cover it, but they can be dual covered with Medicaid, but not Obamacare and Medicaid. That's the big rule. Any questions there?
Thank you for that. That's actually a really great example of how, so New Mexico, of course, not only is it legal and is abortion legal in New Mexico, there's actually no gestational age limit either. So a couple of the later trimester care clinics are in New Mexico in Albuquerque. And so but that's a great example of a state where you have access, but and this part is specifically speaking about, as Sophia was mentioning, there's no protection in the state constitution. Like there's no laws that say abortion providers are protected in any way if they practice in New Mexico. There's nothing that says that potentially like another law could then come along and overturn another law could come and overturn the current state of access because there's no protection in the state constitution. Whereas states like Maryland, New York, California, there's actually protections written into the law that protect access. But also in states like New York and New Jersey, where I have worked or where I am working, even then when insurance will cover some abortion care and not others, and there's plenty of loopholes and prior auths. And so theoretically, New York and New Jersey are also in the categories, I believe they're more in the protected and expanded access categories, but even in states like that, there are still barriers. So it's just incredible how the barriers layer one on top of the other. So thank you so much for that perspective.
I agree 100%. It's not protected, but at least like we got it. So we fight for it.
Exactly. Yes.
Yeah, thank you so much, Sherry. Really just appreciate hearing your experience in the state and hearing just how you're innovating and making sure patients can still get care, the care that they need close to home. Adam, see your hand.
Hi there. Thank you so much for both of you doing this evening. I want to start with that. I was born and raised in Florida, but I've lived in Michigan for the last couple months. So it's a stark difference from where I came from to where I am currently. Florida is, as you can see on the map, a very hostile state to live in terms of what's going on with abortion since the Dobbs decision. But given that I don't live there right now, I'll speak to Michigan. Michigan, when the Dobbs decision took place, it was maybe a little over like 4 months, I want to say, if I'm remembering correctly, that it took for our government here in the state of Michigan to approve Proposal 3, which was the Right to Reproductive Freedom Act. So about November of that year. That put in place a lot of protections in Michigan where it's very safe in comparison to living in a state like Florida, where there are. I've not been keeping up with it given that I don't live there right now, but I know that there are definitely some pretty significant bans and limitations on when or very small windows, I should say, where you would even qualify for an abortion. That said, there's not any, as you were talking about some of the clinics in Albuquerque. I know that here in Michigan, or at least my understanding is that there doesn't seem to be that small window that's in place. So it is there. There's not many barriers in place. They've also removed some barriers as well. So after they passed that act, I know that there used to be like a 24-hour waiting period that was in effect once you decided to move forward, if you decided to, and that's been lifted to make sure that people are able to have that prompt access to care, unhindered, things like that. So Michigan, very supportive, very protected in terms of people's rights to get an abortion. But where I come from, where I was raised, where I spent most of my life, 95% of it, not so much.
Yeah, thank you, Adam, for sharing that. And I think it's really interesting to hear your contrasting experiences between Florida and Michigan. And so, like, how it's like we're living in very different worlds depending on the state that we're in. And even as people that are quite informed and are part of this, are a part of providing reproductive health care, it can be quite challenging to keep up. And so it's like even more challenging for our patients and the folks that are trying to get abortions who might not have the time or the resources to find this information or to keep track of it. So thank you for highlighting that. Yes, Adam?
You're so welcome. There's one more thing I completely forgot to mention that I think is pretty notable. In Michigan, it used to be if you were going to be getting an abortion, you had to see a physician had to do it. That was the law that was in place. That was another, when I was talking about restrictions that were lifted in terms of that waiting period, another huge move, step forward, I should say, was that you no longer need to have a physician perform an abortion. As long as there's a qualified clinician in the state of Michigan that you're seeing, you can get one that way. So it greatly opened up the ability and sites that people are able to go to in order to seek that care.
Thanks for sharing. That's helpful. That's good. Yeah, Michigan is, I did my residency in Michigan, and I graduated in 2018. And so prior to the Dobbs decision, access was pretty spotty, I would say overall. And there were, like Adam was mentioning, there was a bunch of restrictions. But yeah, actually the state legislature really got itself together and passed some really great protections. So Michigan's thankfully has much better access.
Yeah, it's really interesting to see the different paths different states have taken since, Roe or even before then. And there's a lot of innovation happening, more expanded access, and then paired with these like very intense restrictions in other places. So thank you, yeah, to Sherry and Adam for sharing. I think we'll move along, but please feel free to also share. For those of you that wanted to share, please feel free to do so in the chat. Um, and I think like yeah, you all illuminated is that there's a lot of variability, right, in the legality across the US and then also in like clinic availability. And I think there's also these like social elements as well of like stigma. And so depending on the context that someone finds themselves in, whether it's like urban or rural, that also might affect, how close they are to a clinic, but it also might affect like their social environment and how they might be able to imagine even getting an abortion. And so, in addition to these legal barriers, there's many other barriers to getting an abortion. And so, um, I'm going to kind of talk through a few of them right now, but I'd love for you all to chime in the chat with the barriers that you think are most prevalent, or that you've seen your patients experience, or that you can imagine that people are experiencing right now. And yeah, like would love to maybe if you can either come off mute or put it in the chat. Um, like what besides legal barriers are getting in the way of folks getting an abortion?
There's like financial barriers, barriers to transportation, barriers to getting time off of work to get it if you are in a more restrictive state and you need to go to other places. So other than like legal restrictions, there are a few other things.
Yeah, I would piggyback off of Jamie. We're actually both in Tennessee and Memphis, and so stigma is definitely a huge prevailing issue that we see all the time. I mean, I know this isn't necessarily unique to Memphis, but outside of our reproductive health clinics, there are constantly protesters. We have a lot of issues in the city surrounding abortion and reproductive care, and so I would say that's a huge barrier.
Yeah, thank you, Danya and Jamie. Yeah, you covered quite a bit of those barriers, and I'll just add to those, that um, yeah, I think that, folks having to miss work, there's also, the need for childcare potentially, depending on how far someone might have to go. Especially now with the increased presence of ICE and the increased violence from ICE, it's especially like a lot of immigrants and undocumented folks that I've spoken to, like already were fearful of going to clinics and really careful with how they spent time outside of their houses. And now that's just even more difficult. And so really holding space for what they're experiencing right now. And there's also, yeah, a lot of misinformation around what is actually safe or legal. And I think something that I know Lee and I talked about too is like the distrust, there's a certain distrust of medical institutions and medical providers that also can play into this, that folks might have had negative experiences seeking healthcare for other things. And that's just they'll feel it, they don't feel like safe going to a physician or a clinician to get an abortion or to even get information from them. And I think it's important to note too that, these barriers, especially affect people from marginalized backgrounds, and that addressing these barriers is a key aspect of reproductive justice, and ensuring that people can exercise their bodily autonomy. And I'm going to turn it over to Leah to pose a question.
Yes, thank you. Okay, so the other piece of this that is important is what we as providers can do to make sure that we are not accidentally or on purpose criminalizing our patients. And so oftentimes, and this definitely depends on what state folks are in, but even now I've heard, having seen patients from Texas, from Mississippi, from Florida, from Georgia, from basically a lot of places in the South. Oftentimes patients don't, as Sophia was just mentioning, patients don't necessarily trust that they can go to a provider that would be okay with their decision to terminate a pregnancy, and that they have stigma within their own like within the medical field in their community. So in that case, the provider is often the barrier to accessing care. And so have you all seen, if you could give us some examples, put in the chat, feel free to come off mute, of any examples that you've seen in the hospital, maybe in a clinic, maybe stories you've heard of where providers or physicians have actually posed barriers to access.
I'll just come off mute. So this is actually stemming from a somewhat unrelated, well, completely unrelated, I should say, issue. Um, During when we went into lockdown during COVID, there were a lot of physicians that were vocal about their beliefs behind how they felt as what they felt as though was appropriate, and because of that, as a result, as an impact, following once we started getting back to normal again, there were colleagues, friends, family, people that I knew indirectly through those that I worked with in the medical field that because of what they learned about their providers, what they heard from their providers during that time, they weren't even comfortable to start having those conversations. So now they were kind of in a position where my insurance requires me to be in network. I've had this person for years, and I'm not comfortable having this conversation with them wherever they are in their life. So that's one thing that I'd like to share is somewhat an indirect consequence. Not even that the physician was necessarily posing a direct barrier to them, but because of what came from that, because of what patients learned about their providers. I think there's a healthy divide between what relationship exists between a physician and a patient, and how you should be presenting yourself and putting your best foot forward, being professional, and doing your job that you swore your life to do. And putting your patients in an environment where they're uncomfortable to even start having certain conversations with you very much, sorry about that, that was my alarm, very much soils that type of relationship. So that's something I just wanted to share.
Absolutely. Thank you, Adam, for sharing that. And this is something I particularly feel very strongly about, and something that Sophia and I were talking about is your ethical duty as a physician. So there's the idea of conscientious refusal, of course, which is that we can say ethically, I don't agree with the decision this patient is making, and therefore I will refuse to provide this care. This comes up a lot in terms of pharmacists who don't want to dispense birth control. And that's what a lot of the ethical papers are written about. But I feel like in this case, this is not an elective, and a termination of pregnancy is, and when you were mentioning COVID, Adam, something that I thought about during COVID was how people were discussing whether abortion was an elective procedure or not, because only urgent or emergent procedures would be able to go to the OR to avoid the spread of COVID. And so there was debate on, whether, and of course, an abortion is not necessarily an emergent procedure, but it's a time-limited procedure. And so it definitely needs a higher sense of urgency. And so somehow, though, abortion gets left out of these conversations a lot. But again, going back to we swear in Hippocratic Oath when we become a physician to take care of people regardless of circumstance, regardless of their decision. It's not our decision. We're not having the abortion. But we are provided if we have the skill. And so this is kind of where I feel pretty strongly about this too. If you're going into the field of OBGYN where you are learning how to evacuate a uterus and you're learning to take care of patients throughout the reproductive spectrum, then you should be comfortable performing this procedure. I feel like it's similar to being a cardiologist and refusing to take care of someone with blocked arteries. It doesn't make any sense. If you don't want to do that procedure, then you can choose a different specialty. I mean, of course, that's very specific to OBGYN because we take care of pregnant people. Of course, there are other specialties that provide abortion care, the largest being also family medicine. So it's actually abortion providers are still a very small number. It's only 5% of the OBGYN specialty, I believe, which is even smaller than I initially thought it was. It's an incredibly small number. And I don't actually know the percentage of family doctors that provide abortion care, but there's a good number of them. At some conferences, I feel like the family doctors actually outnumber us. And so there's a great number of family physicians that perform abortion care, and that's medication abortion and surgical abortion. But something to consider for your own specialties, you don't have to be either an OBGYN or a family physician to provide abortion care. You can actually learn the procedure. The procedure is actually not super difficult to learn. It's a minimally invasive procedure. It's a minor procedure that can be done in an outpatient setting. However, now in this environment of abortion training, it's very hard to receive that surgical training in some cases, just because the training opportunities are limited now. But medication abortion is still something that any physician can learn. And we'll talk about how easy it is to do that. And so you can consider that when you're considering providing abortion care in a specialty that may not, if you're not interested in OBGYN, you're not necessarily interested in family medicine, you can still, if you're passionate about this work, and this care and this access, you can still provide it. And so going back to the barriers that we can create for patients, we need to make sure to not add to misinformation. We need to make sure we give patients appropriate information. And Sophia is going to share some resources about how, like, what resources you all can use to do that. Giving referrals when it's appropriate, which is always, if you're not providing the service, if you're not providing the procedure or the care yourself, it's your ethical duty to refer. So the doctors, so this kind of, the lines can become blurred here because of doctors who are afraid. And again, I think this is where it's a judgment call in terms of our professional privilege, because we have a lot of power and we have a lot of privilege as physicians. And I believe in these circumstances, we should use our privilege in a way to protect our patients. But I do know that there are doctors that are afraid of giving information or advice for fear that they themselves will be reported. And this is particular in like states like Texas, where there's these bounty hunter laws. That's the only state that I'm aware of at this point that has that type of law. There's no other state that does. And so that is a reason why doctors would be unwilling to share information. But again, I think I can understand in maybe some circumstances, but I really think that's a circumstance where we should take ownership and we should do the right thing ethically, regardless of kind of the consequences in terms of our license, because that's just sharing information. That's not like providing the abortion service itself. But I think that it is our ethical duty to provide that information. And I think, yeah, Sophia, I think back to you about SMA.
Great. So, yeah, thank you, Aaliyah, for all of that. And I think just like given everything that we've talked about, all these barriers that people are experiencing, I wanted to like give a little bit of a landscape of like, so what types of abortions are people accessing? Where are they accessing abortion? Like, what are the trajectories, right? Like, where are they going? And so as from the data that we have, we know that around 73% of abortions happen in person or through in-person clinical care. And then around like 27% actually are with telehealth. And we define telehealth, as a medication abortion provided via remote clinical care. And so that can vary. There's a variety of different providers out there that may provide more hands-on support. That can either be from, a midwife, physician, a nurse practitioner, a physician's assistant, but there's quite a range. And there's also some services that really just send the medication and provide some information about, the protocol, how to take the medication, which we'll talk through in a bit. But it's a little bit more hands-off and it's a bit more of like a mail service. And so I just want to note that like the term like telemedicine abortion, telehealth abortion is like really broad and it can encompass a variety of different things. And I said that number 27%, that's like for the entire US, but that percent actually varies really widely across states where abortion is like permitted or restricted. And in states where abortion is banned, almost 100% of those abortions are provided via telehealth using SHIELD laws, which, as many of you might know, are laws in states where abortion is legal that protect their providers from being criminalized for providing abortion care in states with abortion bans. And so it's been like those shield laws have been incredible in assuring access in those banned states, but obviously can also pose a risk to clinicians. And so we've also seen certain cases, legal cases that have been taken against physicians in certain states for providing telehealth abortions. And
I think the
will,
Attorney
yeah.
General of Louisiana, I believe Louisiana, has now tried to extradite two physicians, one from New York, who mailed pills to someone in Texas, or sorry, in Louisiana. And maybe I'm getting confused with Texas. There was another California physician that mailed pills either to Texas or Louisiana. I think it was Louisiana. But regardless, the shield laws in both New York and California protected those physicians. So the governor of each state said there's no way we're giving this doctor up, and you can take my shield law. And exactly. So so far it's worked.
Yeah.
Thank you.
So, yeah, it's like I feel like every day or like every week there's just kind of like a new legal fight around that. And I feel like they're like, yeah, anti-abortion activists are just trying every way that they can to threaten access. And what we wanted to share is that we can like share a few resources in the chat or after this call. There's, in addition to what Aaliyah mentioned, that like you can get trained on how to use medication abortion and provide that to your patients. You can also refer your patients to a lot of these telemedicine services that exist. And so, that might vary across states. Some telehealth providers only provide care in certain states. Others serve all 50 states in their territory. So it's definitely something that you can also do some research on your own just to see which are the providers that work in your state. But some just quick ones to share that that are like well known are Abuzz, which is provides care through 12 weeks and 6 days. They provide care on a sliding scale from $0 to $150, and they provide clinical support by phone. Another really well-known telehealth provider is called 8Access, and they provide care through 13 weeks, 6 days. And they provide support via email, and they're mostly they mostly mail pills, and from outside of the US. And another one that's been like well known, I think spoken about in the news, is the Cambridge Reproductive Health Consultants called the MAP. That provide care through 11 weeks, 0 days. And so they also have a little bit more of a low touch approach where they will send the pills in the mail, provide information. They mostly do follow up via like a form or a questionnaire 1 to 2 weeks later. And so these are good options, especially for folks that are, trying to get the medication. But I think it's just important to note with like telemedicine, while it can be a really great option for folks, it doesn't always provide that, more accompanied form of care. And so I think another option that a lot of folks have been exploring, and here I'll put a few of these options that I in the chat so you have them with links. And yeah, given that sometimes like as you see these prices, like it can be still quite costly for folks. A lot more people are turning to what's called self-managed abortion. And self-managed abortion is mostly defined as someone who takes abortion pills outside of the formal clinical system, often with trusted support. And this is especially useful and important for folks from marginalized backgrounds, and they can use the self-managed abortion to often circumvent medical gatekeepers, the geographic barriers that we've spoken about, and the legal restrictions that exist to be able to access an abortion. And I've worked on several studies, both within and outside of the US, essentially like studying the effectiveness of self-managed abortion. And what we've found is that, well, actually, I'll dive into that in a moment. But essentially, I'll dive into some of the evidence in a bit. But essentially, self-managed abortion is a safe option that a lot of folks are using. And it's especially useful because a lot of the options out there are like the self-managed options are lower cost and often can come with more accompanied support. I think for some folks, it can feel a little bit low touch just to receive medications in the mail without more guidance, especially since a medication abortion can feel really different depending on your body and your psychological state. And so ReproCare, which is one of the organizations that I work with, we provide a national abortion hotline that has experienced peer counselors that provide accurate information and compassionate support for abortion seekers. And so I'm not promoting us necessarily, but it's definitely an option that you can provide to your patients where we are open. Our lines are open during the week, throughout the day, and folks can call us. We're a hotline, and they can essentially get support at any point they are in their decision-making process around an abortion or any point in their abortion process. Thank you, Danya, for putting those in the chat. And another really good resource too is the MNA hotline, or the Miscarriage and Abortion hotline, that is run by a team of volunteer clinicians that provide advice on miscarriage and abortion. And they're wonderful. And we also at ReproCare sometimes will like point folks to the MNA hotline when there's some questions that folks have that we can't answer, especially if there are complications and we just don't feel like that's, something we feel comfortable answering within our purview. And so they're a really good option as well. Any questions on the resources I just provided before we dive into talking about the evidence for SMA and medication abortion? Awesome. Yeah, and we can maybe provide these resources in a more like organized way. I feel like I can create a little sheet. Great. And so so in terms of the evidence, 63% of abortions, the clinically provided abortions in the US are with medication abortion. And so that number has just been increasing over time, especially given the things that Aaliyah mentioned. It has become a lot harder to get trained in like procedural abortions. And also just like given the demand, as we noted earlier, the demand for the number of abortions is going up with time, even if the number of folks the clinics that are able to provide them is going down. And so medication abortion is kind of in some ways a cheaper and also just like easier option. And from all the evidence that we have, medication abortion is highly safe and effective. And therefore, self-managed abortion with medication is also highly safe and effective when evidence-based protocols are used. And I want to be clear about that because we're very much like it has to be the evidence-based protocols that are in the WHO standards, and also and that are peer, it's like peer-reviewed protocols. And I think it's important to note too that with the self-managed, both with medication abortion generally, and then especially with the self-managed option, it's safe even when people don't have an in-person exam or an ultrasound. In most cases, you do not need either of those to use abortion pills, and serious complications are really rare. And from a study that my organization, IBRIS Reproductive Health, did in Argentina and Nigeria, we were able to show that self-managed medication abortion with what we call accompaniment support. So it's like support from kind of peer counselors, like kind of activists that are trained in the abortion protocol. That self-managed medication abortion is 94 to 99% effective and is comparable to clinic-based care for pregnancies under 9 weeks. And there's other studies that have been done by other amazing researchers, such as one with Aid Access, that showed that 96% of people that received a self-managed abortion with the Aid Access were able to complete without a surgical intervention, and only 1% had any serious complications. And that study also asked folks if they were satisfied, and around 98% said that they were satisfied, and 95% felt that self-management was the right choice for them, which just like shows that people might also prefer a self-managed abortion, especially given the many barriers they might face. And it can give them privacy in their own home. It might be a great option if they don't want to have to drive a really long way or can't afford to go to a clinic nearby. And of course, we also always want folks to have the option to go to a clinic if they want to. Um, and that's where abortion funds come in. And so I think if you have a patient that you're working with that maybe doesn't want to, that wants to go to clinic, abortion funds are always a really good option to point them to for funding. And so I think just all of this evidence is to emphasize that the main risks that people often face aren't medical, they're very much legal and social. And as physicians, as providers, you have the opportunity to make sure that those legal and social barriers are minimized for your patients. And I will turn it over to Leah to talk us through the protocol.
Okay, great. So pop quiz. How many of you know the protocol for medication abortion? You can, if you know, you can, which I'll be impressed. You can come off mute and you can also put it in the chat. And do we have that image? Thank you, Jamie.
Yeah, let me share the image.
So yes, it's so very close. It's mifepristone is the first medication. And so mifepristone is an anti-progestin agent. And so it's a 200 milligram dose, one pill, and the patient takes that and just swallows it. This is usually the step that used to be in some of the old guidelines for some of the old FDA guidelines. This used to be the step that a person would have to do in front of a doctor, which is silly and absurd. There is no need for that. It is not an unsafe medication. But the reason for that was when you are registered to prescribe mifepristone, you are registered under a REMS registry, and this is kind of a higher level of registering medications that are deemed potentially dangerous. And so like chemotherapy medications are on this registry. And so you can't prescribe chemotherapy medications unless you're an oncologist, of course, and you're registered. But in terms of REMS for mifepristone, it's completely a political reason, of course. And so at least in some states now, that restriction is gone. So for instance, in my clinic in New Jersey, I will meet the patient, I'll talk to the patient will have an ultrasound, and then I will answer any questions the patient has after they go through counseling with a counselor. And then if the patient doesn't have questions for me, they are handed the pills, and then they're able to call it, they go home, then they're able to call us with any questions. So it's actually a pretty, in terms of even the clinic visit itself is relatively low touch. Obviously the ultrasound is high touch, but the ultrasound, like Sophia was mentioning, is not required for the medication abortion. If a person knows their last menstrual period relatively well, and is not having any symptoms of ectopic pregnancy, so no pain on either side of on either ovary, and most patients are, and as Sophia mentioned in those studies, most patients are actually very reliable at self-reporting. And that is why most of us in the clinician world don't really see patients who have done SMA because self-managed abortion, because it actually works most of the time. Sometimes we'll see them even in my clinic for a DNC, like a surgical procedure, if after their pills, not all the tissue has passed. Sometimes we'll see those patients, but most of the time the tissue will completely pass, even with some more time, and then we won't see those patients. So going back to the protocol, after the mifepristone, 24 to 48 hours later, but it can actually be as soon as 12 hours. So I would adjust that to 12 to 48 hours later. And this really just depends on the patient's schedule and what they have to do. Sometimes we will kind of manage the schedule around their work, or if they have to get childcare and they may feel like they need some additional assistance if they're having this miscarriage at home. And so when they're ready to take the other 4 pills, the misoprostol, which is a prostaglandin and helps the uterus contract and then expel the pregnancy. So basically the mifepristone helps the pregnancy kind of break down a little bit, and helps the lining of the endometrium shed. And then misoprostol helps the uterus contract and pass the pregnancy. And so it's 4 pills. Typically it's inserted in the cheeks, so 2 on each side and buccal. And sometimes patients can place them vaginally as well. And so they have to remain in the tissue, in the mucosa for like 30 minutes or so. After that time, the patients can swallow the pills. If they're placed vaginally, nothing needs to be done. And then basically 45 minutes to an hour-ish, typically after the misoprostol dissolves, patients will start experiencing cramping, pretty heavy cramping to like kind of to the point of a very heavy period. So I typically ask patients what their menstrual cycle is typically like. And if someone tells me that their period is very heavy, very crampy, very painful, and they're taking tons of Advil and Aleve to manage their menstrual cycle, that is typical for the experience of the medication abortion. So someone's very heavy menstrual cycle that involves pain and cramping and nausea and all of those things, that very much resembles the medication abortion. So those folks who have those more painful menstrual cycles typically do better in terms of like the psychological experience because they're expecting that level of pain. And so it's more of it, the experience varies, as Sophia was mentioning before, depending on the expectations I think that are set. So you want to set very clear expectations when you're counseling a patient that I don't sugarcoat it. I tell them it's going to be pretty crampy, pretty painful, but that it can be managed. So you always want to, you always want to provide reassurance because this is not a devastating thing. This is just a really crappy period, basically, really heavy, crappy period. So heating pads, scheduled NSAIDs, scheduled Aleve, scheduled Advil, and basically just waiting it out. And so the bleeding can get pretty heavy as long as you're not concerned until people are soaking more than 2 pads over more than 2 hours consecutively. That's a lot of bleeding. And then if that's the case, that person needs to go to an emergency room. But if it's anything less than that, especially if someone is 8 to 9 weeks or less, then up to that amount of bleeding is completely normal. And the protocol can be used, the FDA protocol for mifepristone and misoprostol at this regimen can be used up to 10 weeks. And then you can actually use this past 10 weeks, up to 12 weeks, but with appropriate counseling. Because at that point, it's more crampy, a little bit more time it takes to pass the pregnancy. And at that point, so organs and fetal parts start forming at 10 weeks. So everything is very, very small, but it actually starts to, it looks like a fetus at that point. So anything bigger than 10 weeks, you need to provide appropriate counseling about what the patient may or may not see. And if they're comfortable with what they may or may not see. And then in some cases, some people are fine or don't have an issue with that and are fine with it. And other cases, maybe people will be not so fine with that, but absolutely need the care. And so unfortunately, this is the kind of circumstance that map of the United States has left us in, where there are situations where someone may be 12 weeks or so, and the only access they have is the medication, in which case that is safe, and it is fine for them. I mean, it may not be the best experience, but it will provide the care that they need. And then in terms of other symptoms, so there are actually very few complications and very few side effects. The side effects of the misoprostol are nausea, vomiting, and diarrhea, which are not fun, but it's basically like having a GI bug. Some people will not have many side effects, others will have more. Oftentimes we give an antiemetic, we give Zofran for folks to take with them. And we also just tell them that you may expect that. Fever and chills can sometimes happen. A one-time fever with misoprostol is actually relatively normal. But if someone's having recurrent fevers, that's a different story. Trying to think if I'm missing anything. I think those are the major, and bleeding is the primary. So as long as the patient and the accompanying person are keeping track of the bleeding and making sure that it's not excessive, then for the most part, there are very few complications. And then in terms of follow-up, really all that is needed is a pregnancy test. And 4 weeks is probably a little too soon. I would say maybe more like 5 to 6 weeks. The pregnancy test should be completely negative by that point. Another way is a blood test, a beta HCG. That would involve a lab visit or a hospital visit though. And then of course an ultrasound, but that's only if that access is available. So it's completely fine to follow up the medication abortion with a pregnancy test. Are there any questions about that? About the protocol, the experience?
I have a quick question. Thank you so much for that. It was so informative and so great for us to know this, on the front end, whether we're in clinicals right now or pre-clinicals or pre-med, whatever it might be, this information is life-changing. I'm wondering as someone, so I worked for a long time at Choices here in Memphis, as I know we've talked about. And throughout that time, I noticed, I would be like working as a patient educator, like in the room with them oftentimes as they would be receiving their abortions. And then they'd sometimes come back for follow-up. Oh, thanks Pete, for spotlighted me. They'd come back for a physical follow-up sometimes, right? Just to make sure, especially if it was surgical, of course, which I know is not the scope of this specific talk. But I noticed there was, the need sometimes to provide an emotional check-in as well, because oftentimes, they were feeling, especially here in Tennessee, a lot of that internalized shame and talking to us sometimes briefly about it in that passing moment, and then noticing that it wasn't really an integrated part of the checkup thereafter. And so that was a big thing that we were working through at Choices at the time. And it makes me wonder, even in this scope, what is, because I learned a lot from our last Repro Summit here together in the summer, and how I can sometimes err on the side of over assuming that something might be difficult for someone. I think because that's just like the therapist in me. And I always want to acknowledge, okay, there might be grief here, but also abortion is celebration because abortion is freedom. And so I'm always walking that line of offering that full compass support, but not insinuating, right, that it needs to be something that is necessarily felt that way. So just curious about how to best approach that thread line and how to offer support in a way that is comprehensive but does not make assumptions.
I love that question. Thank you, Donya. It's a beautiful question. And I think it's you really let the patient take the lead. I know it sounds a little cliche, but it really isn't, because oftentimes the patient's whole demeanor will tell you everything you need to know. And so if the patient walks in and they're like, I mean, quite literally, I've had patients say, I just don't want to be pregnant anymore. And I ask them, I'll meet them before the procedure, in a surgical procedure, for instance, and I'll say, do you have any questions? Can I answer anything? Is there anything you're concerned about? Is there anything you're scared about? Or not necessarily saying those words, but basically just asking if the patient has any questions. And so oftentimes people would literally just be like, I don't want to be pregnant. I just want to be done. And then I can go have a cheeseburger, and that's great. And that's celebration. And that is abortion is freedom. And this person just doesn't want to be pregnant. And that's my favorite abortion to do. My not so favorite abortions to do are the ones where the patients are super sad. And the ones where it was a wanted pregnancy, and for whatever reason, could be medical, could be social, could be anything. For whatever reason, they can't have this pregnancy. And those are what I call sad abortion, because it makes me sad, because I know that it's not necessarily something a patient wants, but it's something they need. And that is kind of the differentiation, I feel. And then it's also how they feel about that want versus that need, and how emotional that is for them. And so I think for what you were saying, Donya, is absolutely wonderful to offer people that support. And I think it's often easier than you would think to tell who might need it. And oftentimes for instance, patients will come back for their post-operative visit, and sometimes they'll just sit on the table and they'll just sit there quietly, and they'll have tears coming down their face. And I'll ask them, is there anything that you're concerned about, or is there anything you're worried about? And it won't be anything medical. It will just be that this was just a really hard decision for me. And I'm relieved, but it's also just there's a lot of emotions around this. Or maybe I wanted this pregnancy or this baby, but this wasn't the right time in my life for it. And so the emotions are incredibly varied, different levels of sadness or I wouldn't say regret, or it's maybe a bittersweet type of feeling. But you kind of sense it from each patient. And sometimes people will just straight up tell you, like I said, either this is making them incredibly upset, or this is what they absolutely want and desire. And then there's everything in between. And so absolutely, I always offer that emotional support. And there's also hotlines, warm lines, for patients as well. Another's, I think the best one is like Exhale Pro Voice. Let me see if I can find that to put in the chat as well. Thank you for that question.
Thank you so much. Thank you so, so much. And others, other questions, feel free to unmute or place it in the chat. And please do take a moment to look at that link as well for our Repro Summer Institute that's coming up. Well, not really coming up, but it's a life-changing experience, and we could not say more about the Reproductive Health Project. But yes, I'm going to mute myself. Please feel free to ask your questions.
Donya, can I speak on this? This is Sherry. As a peer, I do 100% telehealth. All of my patients or all of my clients are over the phone, and I can't tell where they're at. They're not crying on the phone, like that does happen, but every single one of my clients, I give them a basic rundown. This covers one of four things. Your body tricked you, which happens sometimes, and you're pregnant and you deliver, you miscarry, or you decide to terminate. Give them that. Give them on if you for health care because
Sherry,
it's
honey,
not available after the procedure.
we lost you just a little bit,
Oh no! Oh no!
but it was
How about
so
now?
good. It was good. It was great. You can keep. Okay, one more time. Say something. I feel like I'm on a walkie-talkie. I'm like, over.
Is that better?
I think so. Okay.
No.
Okay, go
Now?
on. I think so. Carry on, my dear.
Okay, so I just tell them if they need it, please seek it now. And I give them warm line numbers and stuff like that. So that's something that I do as a peer.
Thank you.
Yeah, I think it's important to remember that there's like truly a whole abortion ecosystem out there of different resources. And so you're going to do the best you can as a provider. And like you might have more time to provide, emotional contention for a patient, or you might not. And there's, Repro Care is an option. There's M&A Hotline, Exhale. And then there also are a bunch of other, resources like abortion funds that also can just help patients afford their in-clinic abortions. And so I think there's a lot of really wonderful resources on the AMSA website. And you can also do research a little bit on your own for the context in your own state, so you can feel more informed on like what might be the best option for your patient where you're located. But this was such a wonderful discussion. I hope you learned about some new resources, and just really grateful for you all for being here tonight, and for fighting for reproductive freedom.
Thank you so much.
If you're ready, unmute and clap for our wonderful speakers. Zoom is a weird place, a beautiful place, but a weird place. Thank you both so, so much. No, please, Aaliyah.
No, I was just thank you all for being here. It's been really wonderful, and you guys have had great questions and comments. And Sherry, you're doing really awesome things. So thank you all so much.
Thank you both from the bottom of our hearts. This not only, again, allows us to be more equipped advocates in like the general sense, like we keep talking about with our confidence in our tool bag, but we get actual skills tonight. We get to take away these graphics. We get to take away what we've been learning about our state laws. And this is just, everything that we could ask for. Truly, everyone, let's give another, moment of gratitude for our incredible speakers, for your time, for your energy, for the work that you're doing in the world. You are living models of this advocacy and this justice and the way that you live your lives. And we know that you're tired and we appreciate that you're taking time to be here on a Wednesday evening. And thank each of you who have taken your time to be here with us as well. I want to highlight specifically, everyone, but our AMSA Reproductive Health Project, Becky, Jeff, of course, Nikita, all of our staff that work tirelessly on this project. If anyone wants to say anything, please feel free to. You don't have to, but if you want to say something, I'll shut up for a second. Okay.
Thank you, Donya.
Okay. You're like, that's a wrap. Okay. Anyways, my friends, thank you again. And thank you for caring about reproductive justice and autonomy. We will see you here soon. We'll flow into the community building hour. I have updated all of the resources you have seen here tonight on the website. Feel free to take a look and feel free to reach out to our lovely speakers if you so wish. Until soon, we'll see you tomorrow.
Thank you. Night.